this is the last talk of the session and we're just in time. I'll just go through our experiences with extensive viral retinitis causing retinal detachments. So these can be from CMV retinitis, which is very common, or they can be from acute retinal necrosis. Now, when we see a patient with extensive CMV retinitis, the first thing we do is give intravitreal ganciclovir, because that gives almost immediate response, as you can see here. And within a week, we are able to operate the patient. As you see here, extensive retinitis, multiple breaks, but within 10 days, we were able to operate her, and 2 weeks later, you can see that she has very good situation. So intravitreal ganciclovir injections every 2 to 3 days, and then take up for surgery as soon as the retinitis seems reasonably inactive. And these cases of CMV retinitis will require long-term tamponade, because the retina is thin, a high chance of retinal breaks, as well as high chance of recurrent retinitis. So we need to keep the oil, so use oil which will emulsify slower, and for that reason also remove the lens in every case, because cataract will be forming. And these cases can tolerate oil for many, many years without any emulsification, possibly because there is no immunity, so poor immunity causes less inflammation also. Many of these viral retinitis detachments can just be treated with laser demarcation, because the surgery is very complex. So if you can avoid surgery, I have many patients who have successfully reattached just with, managed just with laser. Now every case needs, almost every case, even young patients, a phaco is done because long-term oil. And you see a large area of retinitis on your left side. And the entire area can be treated as one large break. Instead of looking at the multiple breaks, you see this hole is like a sieve. The entire retina becomes studded with breaks. So your suction has to be very low, cutting has to be very high. The probe tip has to be facing the vitreous anteriorly, otherwise higher chance of enlarging these breaks. And keep the infusion pressure also relatively low, otherwise the jet stream injury can enlarge these breaks. Minimize cryo because of, again, causing more atrophy. And also minimize the use of steroid to identify the vitreous, because the risk of reactivating the virus from local immunosuppression. You can use an alternative site to create a drainage retinotomy, because this area is already extremely thinned out. And then do the laser in such a way that the entire area is treated like one large break. And you can see how it has been treated like one large break in the sides. Again, to show the extreme thinning, extensive extreme thinning, there's a large break already here which can be used like a drainage retinotomy. The entire retina is thinned out. But these cases do very well, surprisingly. Keep the turbulence little low to avoid new breaks formation. And use laser also should be mild. And you can see that there is a residual fluid left behind, so another retinotomy can be made for the posterior fluid. Now in these patients, again, it's good to use an encircling element, because there are peripheral breaks which can be supported well by the band. And also there is late traction can happen, especially in ARN. Traction and PVR is not a feature of CMV retinitis, but of ARN. And there the late traction can be counteracted. Though you can have a very good posterior pole, the periphery is supported well. As I said, avoid cryopexy to avoid atrophic breaks, and also avoid triamcinolone to reactivate the virus. A common problem is, as their immunity improves, they start developing cystoid macular edema. Oral steroids generally do not work. With oil in the eye, it's a little risky to give intravitreal steroids, especially DEX implant, because that has been known to cause acute retinal necrosis with oil, or epiretinal proliferation, or even it can get trapped at the macula, causing a macular hole. Or it may be simply ineffective. So in those cases, you may have to remove the silicone oil. If the patient's CD4 count is good, immunity is good, then you can give a DEX implant after removing the oil. That's what I have had to do for most of the patients. The virus can reactivate if the patient's immunity has not improved, and then you have to give oral valganciclovir or intravitreal. Ganciclovir can be given with oil in situ. ARN is slightly different in that RD usually happens after the ARN has become inactive, membranes have started forming, and then there are tractional and combined rhegmatogenous detachments. ARN can also present with posterior retinitis along with peripheral retinitis, and when there is a sudden vision loss in a patient with ARN, you can understand that very high chance he has developed a retinal detachment. But the media is usually hazy, the index of suspicion has to be high, and a B scan would give the diagnosis. Now this is the last situation, a case, very interesting case which I wanted to show. HIV positive patient with very low CD4, 24 only. We operated, she's doing well. She started like that on the top, but within 2 weeks could operate her. And then you see post-operatively, she develops new breaks here, which lead to a detachment. So now instead of reoperating, we decided to prone position her for these breaks. And within 3 days, you see the breaks have closed, and now we could laser these breaks. And she was doing well, very well actually. But then she had a new problem 2.5 months later. She came with hypopion and endophthalmitis. Now we were wondering whether this was late onset post-operative endophthalmitis, but actually it turned out that she was also quite sick at this time, and lymph node biopsy also showed the same organism that we isolated from the vitreous, which was non-tuberculous mycobacteria, which is usually not a operative organism anyway. So what I'm trying to say is that these immunocompromised patients have multiple problems. Now we could settle the retina, but we had to deal with endogenous endophthalmitis because of the low immunity. And then they develop immune reaction, immune recovery uveitis. So these are the various problems we can face one after the other in these patients. Thank you very much.
Yeah, thank you very much, Dr. Mallika. Just, I think, couple of questions.
Yes.
Because with the new literature support suggests that practically, but probably there is no role for prophylaxis in when you're dealing with this viral retinitis. Your take on that? You touch upon that one. Just can you just elaborate more about that?
Yeah, the literature says that if a patient has is immunocompromised, there is no role for prophylactic valganciclovir orally or systemic IV ganciclovir just to prevent CMV retinitis or even to protect the other eye. You have to treat only if there is a known disease. Either it is systemic disease or it is in the eyes. But not just because CD4 is low, every patient starts getting ganciclovir. Was that your question?
That's one that also and role in the prevention of detachment, laser or adding and like antivirals.
Prevention when you see CMV retinitis already.
Yes, yeah. And yeah. Same thing, ARN also as well.
Yeah, ARN. No, I think prophylactic laser may have no role. It may in fact induce an RD because these are very thinned out retinas. And then they are also very extensive. A laser would be very extensive. And the retinitis can progress, so your laser would be ineffective then because it would have gone beyond your laser line. So I don't think there is any role for prophylactic laser. But once then as a RD, I have several patients who have been demarcated.
That's what previously we used to try laser actually, assuming that if you do laser, you will just limit the extent. We realize that it doesn't happen. What we really need to do is control the inflammation, and that is what is going to help you at all, not just adding laser or something. But it really, if it's inflammation that runs through, eventually it is going to tear off further.
Does the CD4 count make your decision to operate, like when to operate?
No, not at all. No, these RDs are an emergency. So we have to operate as soon as we can. CD4 is not a criteria, but retinitis activity is a criteria because that might make the surgery ineffective if it's active. So we can wait for about 10 days, give intensive intravitreal injections, and then go for surgery, but not CD4. That takes a lot of time, 3 to 6 months minimum. You can give it. You can do it. Yeah, any questions from the audience for any of the talk, please? There was nothing at all from the audience. Yes, doctor. Mic.
Can you use mic here, please?
He's asking any role of infusion for intravitreal ganciclovir during surgery. It's not necessary because we would have treated, and now we have oral valganciclovir which has very good intraocular bioavailability. So we continue these patients for several months on valganciclovir oral. So And we can give intravitreal postoperatively, so there is no role, but it is described. Intravitreal injection is described.
Along with vitrectomy.
Yes, infusion. Can be done, but I don't see much role because we would have already prepared them. They would already be on oral Valgan and they would continue that postoperatively.